taking them to next stage of disease without their knowledge, without their counsel. So these kind of things, really happening. And I will say a big word to all my junior doctors friends. In this COVID-19 fight, the entire burden is on the junior doctors of the country, because they are the one who go nearer to the patient and touch the patient. Even seniors, consultants, professors, they all view the patient from a distance only. So the junior doctors everywhere, I can see that many of my JDN office were themselves got infected with the COVID, and for God's sake, they all improved. And everywhere I can see that they are also undergoing lots of stress. Their living conditions, their quarantine not being sanctioned, their pay also not fully sanctioned. Those are so many issues. Having given this important job to shoulder to the young doctors of the country, their interests are not met fully. That is a very sad sort of affair that we are dealing day by day in the IMA JDN platform. In spite of all this stress, our people have done wonderful job in running a helplines, in running various kind of telemedicine consultations in several parts of the country. So I must say that the junior doctors of our country are doing wonderful service at this point of time. So it is very timely that Venkatesh Karthikeyan, Shiv Joshi, and all my team decided to have this webinar with an expert like Dr. Surendra Kannan. At this point of time, I should also condole the death of our Professor K.K. Agarwal, because we had so many webinars like this last year, and also this year also. He was always willing to help junior doctors to enrich their knowledge about COVID-19. He had probably done 536 webinars in the COVID time, if I remember the number correct. Such a wonderful person we lost. I pay homage to him in this occasion, and we also had a remembrance meeting yesterday. So there are so many other faculties, our own Indian faculties have gained so much of knowledge, compared to other foreign faculties. We have gained so much of knowledge, changing science of COVID-19. And happy to see that there are so many webinars like this where the knowledge is spread, so that people are directly benefited. The same day, I can see that the things are applied to the patient and getting the benefit. So in this way, this meeting is also held. I expect a very nice discussion in the meeting. I welcome all my office bearers, including Shiv Joshi, Karan Juneja, all have joined. I think I can see, and all of them, I wish all of them to be very safe in this COVID pandemic and have a wonderful time, wonderful session ahead. Thank you very much for the opportunity. I once again welcome our faculty and welcome you all. Over to you, Venkatesh.
Thank you so much, sir. Not only sir is the national chairman of IMA JDN, which is apt for this welcome address, but sir also runs a COVID care center in his native place, HeDaL. It started as a 50-bedded center with giving free treatment, but now sir is giving treatment to more than 100 people, and directly under his supervision, thousands and thousands of general public are being provided teleconsultation. Sir's team is helping for arranging oxygen, all the medicines, and sir is doing an extensive service not only in this wave but even in the first wave, for which he has widely appreciated by the government of Tamil Nadu, including the Erode collector. So thank you so much, sir, for inspiring us. And I welcome our national convener, Dr. Shiv Joshi, sir, and National General Secretary, Dr. Karan Juneja. Dr. Karan Juneja, has he joined? Okay. If not, we'll proceed ahead. So as we know, as doctors, irrespective of our specialty, okay, Dr. Karan Juneja has joined.
Shiv Joshi is there.
Okay, sir. Sir will give the vote of thanks, sir.
Okay.
So I will go to the speaker directly. As doctors, irrespective of our specialty, we are working in COVID wards for more than 1 year, and hence it is mandatory to have in-depth knowledge about the disease. We are learning new things about the disease every single day, and the guideline is changing rapidly. Definitely, we would have seen COVID patients from a physician's perspective, but how does it look from a public health expert's point of view? To share this, I request our speaker, Dr. Surendra Kannan sir, to this webinar. Dr. Surendra Kannan sir is from Chennai. He did his MBBS from PhD Coimbatore, MD Community Medicine from Calicut Medical College, and sir also conferred a DNB degree. Sir is currently an assistant professor in ESI Hyderabad. I take immense pleasure in welcoming you, sir, on behalf of IMA JDN. Welcome, sir. Audience can type their questions in the chat box, and it will be answered by sir at the end of the session. Over to you, sir.
Okay, I'm audible?
Yeah.
Yes, sir.
Oh, okay. Thank you so much, the Indian Medical Association Junior Doctor Network. Thank you so much, Dr. Abul Hasan sir. Thank you so much, Venkatesh, and the office bearers of Indian Medical Association for inviting me for this talk of the webinar, the COVID-19 Vennatively. Nice introduction by Dr. Abul Hasan sir regarding the current situation of this crisis. And today I am going to show some light on this area of COVID-19 Vennatively. So my presentation is actually a series of webinars. So we am starting with the first presentation of this COVID-19 Vennatively. I will share my screen and directly I'm going to my presentation. Is it visible, Venkatesh?
Yes, sir, it is visible, sir.
I will put the slide screen now. Okay, I think I am visible now. Shall I start?
Yes, sir, please do, sir.
Okay. Okay, so once again, we'll start the webinar. Myself, Dr. Kannan, Assistant Professor, Department of Community Medicine, ESI Medical College, Hyderabad. And currently, I am also a committee member for COVID-19, both in vaccination and also in the COVID-19 since it started in the college. So based on my vast experience in this COVID-19, I will just show the presentation of this webinar COVID-19 Vennatively. So I dedicate this presentation to Dr. K.K. Agarwal, sir, who is an inspirational leader. I have seen a lot of YouTube videos of him and I got inspirational from him. I dedicate this presentation to him. And my overview of the presentation will go like this in this order. And we will see the case definitions that has been changed with the change in the recent epidemiology of the COVID-19. And we will see the categories based on the symptomatology, how the symptomatology have been changed, and categories based on clinical severity. So I'm covering both the COVID-19 in the view of clinical specialist and also in the perspective of how a clinician also should know the management guidelines, because irrespective of the thing, we are all working in COVID, so we also know our management guidelines. And lab investigations, what are the lab investigations we should be aware of that, and treatment guidelines, what are the changes. You know, the recent drug has been approved, 2-deoxy-D-glucose has been approved. We are going to discuss that. And now our next biggest headache is mucormycosis. COVID along with the COVID-19 pandemic, we are also facing this mucormycosis. And rule of 3 in management of COVID-19. And I will show some light on this third wave, how what is the chances of third wave, whether it is there or not, and how to prevent this third wave. So I will start the presentation with the changes in the definition of the suspect case. Patient with any suspect case means any patient with acute respiratory illness or symptom of respiratory disease or history of travel to the residence in the location reporting community transmission of COVID-19 during the 14 days prior to symptom onset, or patient with any acute respiratory illness or having in contact with a confirmed or probable COVID-19 case in the last 14 days, or any patient with severe acute respiratory illness. Now, any severe acute respiratory illness is considered as COVID unless otherwise proved. That is fever or at least one sign or symptom of respiratory disease, that cough or shortness of breath, or in any absence of alternative diagnosis that fully explains the clinical presentation. So what I want to stress here is any acute respiratory illness and any case of fever. You can see that fever, any case of fever should be ruled out for COVID unless otherwise proved. And probable case, what is meant by probable case? A suspect case whom testing of the COVID-19 is inconclusive. Nowadays we can see that there are a lot of cases, even day to day we have seen that RT-PCR negative, CT positive, RT-PCR negative, CT positive. This kind of variant diverse situations we are seeing, that considers a probable case. or suspect case for whom testing could not be performed for any other reason can be considered as a probable case. And confirmed case is a person with laboratory confirmation of COVID-19 infection, irrespective of the clinical signs and symptoms. So they are the confirmed case. So now how the second wave of COVID-19 presenting in our situation. This is very important because in first wave we have predominantly a pulmonary disease. It was a pulmonary disease predominantly in the first wave. Now it is changed its little bit course, becoming more invasive and angio-invasive, or becoming more vascular kind of. Now it's presenting with stroke in the any stroke in young COVID-19 should be ruled out. Multi-vessel or large vessel stroke also it's presenting. It's presenting as Kawasaki-like illness. Multi-system inflammatory syndrome is also directly presenting within some adults. Hyperinflammatory shock or toxic shocks like syndrome in children. Acute myocardial infarction. Any person with any young person with acute myocardial infarction, or irrespective of the age group with acute myocardial infarction, COVID-19 should be ruled out. Guillain-Barré syndrome. COVID-19 also presenting with Guillain-Barré syndrome, a kind of ascending paralysis, viral encephalitis, and also presenting with acute disseminating encephalomyelitis, olfactory or gastatory dysfunction or conjunctivitis. Now you can see the pale eyes in many of the patients with COVID-19. So this is how the second wave this year has changed its course with the diversing various of clinical manifestations. And this is the very basic thing about the management of COVID-19 from a clinical and public point of view. You will start with incubation period, symptomatic phase, and early pulmonary phase and late pulmonary phase. You can see that the first 10 days is the viral replication phase where the antiviral treatment work. From the 10th day, initially the viral replication, the viral will multiply. That is, if your immune system is good, 95% the people are getting cured. 95% people are getting cured. The remaining 5% are going for the next phase of early pulmonary phase and late pulmonary phase. In the late pulmonary phase, there will be viral debris, and at the same time, there will be an activation of the cytokine storm. There will be activation of cytokine storm, and there is the immune dysregulation where we have to go with anti-inflammatory therapy in the form of steroids and in the form of anticoagulant. That is a thing. So that this is the basic clue in the current understanding of COVID. First 10 days is the viral replication phase, followed by early pulmonary phase and the late pulmonary phase. Now, how to categorize based on symptomatology for the public, for a general practitioner or who are working in COVID OP. Category A, mild sore throat, cough, rhinitis, and sometimes it's presenting with the GI manifestations and loss of smell. Loss of smell should not be ignored. Or category B is category A. So along with this comorbidities, those with comorbidities will come under category B. These comorbidities include lung disease, heart disease, liver disease, kidney disease, and the uncontrolled diabetes, cancer, and the HIV, AIDS, and cardiovascular disease. And those who are on long-term steroids and immunosuppressive drugs are considered in category B. And those who are pregnant lady is considered as category B, and the age more than 60 years comes under category B. So this is considered as the symptomatology classification. Category C comes under category C in that breathlessness, chest pain, drowsiness, and fall in blood pressure, hypotension, hemoptysis, cyanosis will be there, and children with the influenza-like illness and with red flag signs. So these are the now this is the next area where we have to concentrate on the children. If at all third wave comes, which we will discuss about that later. So worsening of the underlying chronic conditions will be considered in the category C. Suppose initially patient with diabetic and the diabetes is worsening, or that so will consider as a category C. So based on clinical severity, mild cases no breathlessness or hypoxia, moderate cases dyspnea or hypoxia, fever, cough, and SpO2 less than or equal 94% with a respiratory rate of more than 24. That is moderate. And severe means these class 3 symptoms like tachypnea, severe respiratory distress, and oxygen saturation less than 90 in the room air. So these are the clinical severity cases based on the pulse oximeter findings and the tachypnea. So what are the lab parameters which you have to do at admission is CBC, RFT, LFT, CRP, very important, and random blood sugar, electrolytes, ECG, and pulse oximetry because of the varied manifestations of the COVID-19 in the second wave. If clinically indicated only, we have to go for CT scan. Otherwise, it is not needed. Nowadays, people are doing CT scan on the second day of illness. It is wrong. The CT scan and X-ray only if it is clinically indicated in the case of decreasing saturation or in the case of increased fever that is needed. And those with HIV, we can HBsAg, HIV should be they have to do the HIV, HBsAg, HCV, D-dimer very important, ferritin, LDH, CPK, and procalcitonin. So to repeat, this is a very important. You have to repeat once if you clinically indicated, and if you are doing the blood test, you have to repeat the test every 48 hours. That is very important. Same CBC, creatinine, LDH, CRP, ferritin, D-dimer. We have to repeat every 48 hours. For immunocompromised patients or transplant patients, we also have to rule out the opportunistic mycosis, mycobacterial tuberculosis, and pneumocystis pneumoniae. Now we have to also careful about the mucormycosis. So how to classify this with the comorbidities? High risk. These are high risk groups: uncontrolled diabetes, hypertension, cardiovascular disease, and pre-existing pulmonary disease, chronic kidney disease, chronic liver disease. Those who are on immunosuppressive or biologicals, and HIV CD4 count less than 200, age more than 65, and there is obesity. BMI more than 30 will be considered in the one of the categories as high risk. Hypoxia and tachycardia, respiratory distress, hypotension, altered sensorium, and PaF2 by FiO2 ratio less than 300 millimeter mercury. Coming to the lab values, when the CRP more than 100, or creatine phosphate kinase twice the upper limit of normal, ferritin more than 300, LDH more than 245, any TROP-T elevation, because now it is presenting with acute myocardial infarction also, and D-dimer more than 100, and with multi-organ dysfunction. These are the indicators of multi-organ dysfunction with observed lymphocyte count less than 0.8, neutrophil lymphocyte ratio more than 3.13. So these are the lab, based on lab parameters, we have to assess whether it is high risk or high risk. Coming to the treatment guidelines that is there. So category A, who are presenting with only mild sore throat and this thing, we have to go for symptomatic treatment. And best thing is we have to go for home isolation. But as Abdul Hassan told that home isolation is little bit not helpful. So we have to reassessment that every 28 to 48 hours for change in category. So for that, maybe sir would have told that monitor for dyspnea, hypoxia, high grade fever, any kind of severe cough, altered sensorium, and excessive fatigability in category A, they have to change to category B. So category B, what are the management is ivermectin 200 microgram per kilogram per day. In our day, we are giving 12 milligram once a day for 3 to 5 days, and meter dose inhaler or dry powder in the form of budesonide 800 microgram twice a day if symptoms or persist beyond the 5 days of disease onset. Only after the beyond the 5 days of disease onset, we are advising this drug. Category C, we can give favipiravir 1800 milligram twice daily for 1 day, and for 800 milligram twice daily for a total of 7 days. Again, we have to give tablet ivermectin 12 milligram once a day for 3 to 5 days, plus meter dose inhaler or dry powder in form of budesonide 800 microgram twice a day if symptoms persist beyond the 5 days of disease onset. So if there is moderate category C with moderate severity, we have to start injection methylprednisolone not in the first 5 days. Okay, after the 5 days only. Now this when I made this presentation 2 weeks back. This was the guidelines. Now because of the increased incidence of mucormycosis, we have to go for dexamethasone 0.1 to 0.2 milligram per kg per day for 5 to 10 days. That's how the disease epidemiology is changing, and we are getting new understanding in the management of this COVID-19, because methylprednisolone is again a life-saving drug, but still there is over-the-counter drugs and this unjudicious use of the steroids. Now because of the over prescription, now the mucormycosis is coming. So we are going for injection dexamethasone. Anticoagulation guidelines should be started, that I will tell later in the course of my presentation. And in those of severe disease, when there is tachypnea more than 30 per minute and saturation less than 90, we have again go for increase the dose of steroids of injection methylprednisolone 1 to 2 milligram per kg per day for 5 to 10 days, or injection dexamethasone 0.2 to 0.4 milligram per kg per day for 5 to 10 days along with anticoagulation. The steroids is for the 10 days. You can remember, you can see the steroid is for 10 days, and the anticoagulants I will let it know that. Now, what are the emergency use of approved drugs? These are the drugs that are approved with the emergency approval. One is remdesivir. Remdesivir is, we can see a lot number of queue standing in the various states for getting this drug. But unfortunately, many studies have shown that remdesivir has not have much role in management of COVID-19. Remdesivir only decrease hospitalization. Only decrease the days of hospitalization. If there is 5 days of hospitalization, it will reduce to 2 days. That's all. Remdesivir does not prevent death. Remdesivir does not prevent severity. And remdesivir does not work in asymptomatic. Remdesivir has no use if the saturation is more than 95%. Remdesivir has no use if the saturation is less than 85%. So it is like a Kedar Jadhav in Sunrisers Hyderabad team. I want to useful for any of the thing. So this is a moderate and severe disease. Only those who require supplemental oxygen, only remdesivir help, and it should be used within 10 days of symptom onset. Again, it is a public health problem because most of the patients don't know when their symptom onset. They are coming at the day 20 after symptom onset with remdesivir. Remdesivir won't work because remdesivir is an antiviral drug. It is used only in the first 10 days when there is viral replication as is shown in the my previous diagram. So and before using remdesivir, there should not be any renal or hepatic dysfunction, and not an absolute. It is not, though it is not an absolute contraindication. And the recommended dose is 200 microgram IV on day 1, followed by 100 milligram IV daily for the next 4 days. This is the remdesivir dose. And now the next one is the tocilizumab. Tocilizumab, you can see that it is an ILI. ILI means interleukin inhibitor. So interleukin inhibitor, only this is used only when these four categories should be met. Then only we should use tocilizumab. Tocilizumab should be used only in severe disease. What is a severe disease? Preferably within 24 to 48 hours of onset of severe disease or any ICU admission, or when there is significantly raised inflammatory markers, especially interleukin 6. Based on the recovery trial, it is shown that the cutoff is more than 75. This is tocilizumab is used. And when the situation is, when the patient condition is not improving despite the use of steroids, we can go for tocilizumab. And no active bacterial, fungal, or tubercular infection that should be ruled out because it is an immunosuppressant. So that we should rule out this bacterial, fungal, or tubercular infection. Tocilizumab, the recommended dose is 4 to 6 ml per kg in 100 ml normal saline over 1 hour. That is a single dose therapy of tocilizumab. Tocilizumab you should use only in severe cases. And the recently approved drug that is 2-deoxy-D-glucose from May 1. May 1, it is given as an emergency use approval. It is a oral powder drug available in sachet form. It is produced by DRDO India. It is mixed with the water and give it to the patients for 5 days before bed in the morning and evening, before food in the morning and evening. How this works is a mechanism of action. It prevents the once the glucose, this 2-deoxy-glucose is a biochemically altered structure of D-glucose. There is a deoxy chain where there is OH is replaced by H hydrogen group because deoxy, no. So this is O is removed and replaced H group. This get accumulated in the cells. So the virus will not get multiply because the glycolysis will not happen. You know, the glycolysis, the conversion of the glucose to glucose 6 phosphate, that doesn't happen. And this deoxyglucose helps in cutting down the patient's reliance on medical oxygen because once the viral infected cells destroyed, there is no need of oxygen is the proposed mechanism. Basically, it's an anti-cancer drug that helped, but it is now we can orally in the TV or the media reporting that the people are getting cured with this emergency use approval drug, but still it is in phase 3 trial. I still we don't know the clear picture of the efficacy of this drug of this 2-deoxy-D-glucose at how long I can use or whether we can use in the public added in the algorithm of the management. We don't know. Again, the side effects also don't know the clear picture of side effects because when it is used as an anti-cancer drug at the dose of 63 milligram, it has caused QT prolongation. So we don't know the side effects profile in COVID-19 patients. But still, when there is light at the end of the tunnel, we need some drug. So maybe this is tried in the various hospitals, and orally also we are getting the good results that the patients are improving saturation gets improving and their oxygen demand is reducing, but it is only a oral opinion which cannot be taken as evidence. So other drugs like ivermectin, the special mention should be used because we should be given high-risk patients when there is age more than 60 years, cardiovascular disease including hypertension and coronary artery disease, chronic lung, liver and kidney disease, cerebral vascular disease and obesity, ivermectin should be given. Pregnancy category C, pregnancy we should avoid ivermectin. Ivermectin also excreted in low concentration human milk, so it is better avoid in the lactating woman. Metabolized in the liver by cytochrome P450, so liver function test is mandatory. Azithromycin, if we used along with ivermectin, azithromycin will increase the serum level of ivermectin, and concomitant alcohol use increase the side effects of ivermectin. So this is the drug that is used in most of the states. Some states are not using, depends on the state's protocol, but still ivermectin is a good drug. It doesn't cause much harm. There's no much side effects, but still it has shown to reduce the side effects in the thing. And the anticoagulation, again, very important part. It is used in the moderate to severe disease. Anticoagulation should be started. And we are now, there is two types of coagulation. One is the prophylactic dose anticoagulation or high intensity anticoagulation. So we have to go for prophylactic dose anticoagulation, which is, so therapeutic anticoagulation. What is therapeutic anticoagulation? Means suppose a COVID-19 patient present with a venous thromboembolism or arterial thrombosis, there I have to go for therapeutic anticoagulation. So all admitted patients, all admission patients of this COVID-19 should be screened for venous thromboembolism risk factors with the signs and symptoms of DVT, pulmonary embolism, and the bleeding risk. Or we have to see where there is an increased risk of bleeding with the platelet count is monitored serially every 48 hours, or INR more than 1.8 is considered. And all patients should receive venous thromboembolism prophylaxis unless they are contraindicated. So when there is BMI less than 40 and the creatinine clearance is more than 30, enoxaparin is 30 microgram subcutaneous for 12 hours, every 12 hours we can give. Or when there is creatinine clearance less than 30, same enoxaparin subcutaneously daily. Alternatively, we can go for heparin. When the BMI is more than 40, when the creatinine clearance is good, enoxaparin 40 milligram, we can increase the dose of enoxaparin because obesity itself is a risk factor for the thromboembolic manifestation. So at 12 hours, if the creatinine clearance is less than 30 and enoxaparin 40 milligrams subcutaneous daily, this should be continued for 3 weeks. This is a 3 weeks therapy for post discharge. Also, patients should continue the enoxaparin. That is another mistake that is we are doing in the management. After the discharge for 3 weeks, we should continue the enoxaparin. And therapeutic anticoagulation. What is therapeutic anticoagulation? Suppose a COVID-19 patient presenting with a confirmed case of venous thromboembolism based on the positive diagnostic criteria with a leg ultrasound, or when there is a CT angio, we have high clinical suspicion in case of suppose a patient with diabetes and also risk factors for venous thromboembolism. We have to go for the therapeutic anticoagulation. In that, instead of low molecular heparin like enoxaparin, we have to go for the oral agent in the form of apixaban. Apixaban is a factor 10A inhibitor, factor 10A antagonist, or rivaroxaban. Apixaban dose is 10 milligram per orally twice daily for 7 days, then 5 milligram per orally for twice daily. Rivaroxaban 15 milligram per orally twice daily for 21 days, and then 20 milligram daily. And duration is for 3 months. Initially, that is for 3 weeks. That prophylactic dose of anticoagulation is for 3 weeks, but in this therapeutic anticoagulation, it should be continued for 3 months, and we have to be constant vigilant about the individualized assessment for the in there is case of recurrent venous thromboembolism and bleeding. Based on that, we have to continue the apixaban and rivaroxaban for 3 months. Why anticoagulation? Because the profile the picture of the disease has been changed. So when you only suspect pulmonary embolism when there is hypoxia plus altered coagulation profile. Suppose a COVID-19 patient during the course of illness, if D-dimer is keep on changing and the patient oxygen is not improving, then we have to suspect the pulmonary embolism. And when there is increase in D-dimer from baseline and acute worsening of oxygen, so our blood pressure tachycardia, we have to consider the pulmonary embolism. Why we have to go for the early anticoagulation? We are starting at the as soon as the in moderate case and severe case, we are starting on the 5th or 6th, 5th to 10th day, because there is a COVID-19 associated respiratory disease which associated with pulmonary vascular thromboemboli. And autopsy studies from various countries have shown that venous thromboembolism in deceased coronavirus patients So it is not a purely a vascular disease, not a full pulmonary disease. So that is the thing. And early anticoagulation also prevent the propagation of microthrombi at the disease presentation, because some people are silently dying with the pulmonary embolism, that we can prevent. And early anticoagulation may be associated with decreased mortality. And why we are going for heparin? Heparin is heparin also has the property of binding tightly to COVID-19 spike protein, and heparin also downregulate the interleukin 6, which directly hamper the immune activation. That's the reason we are starting the early anticoagulation. And what are the take-home points? What are the take-home points for the management of COVID-19? Avoid using NSAIDs for very large way. Like suppose I have seen people are prescribing ketorolac, just like that diclofenac for the body pain in. Suppose patient presents the body pain, they are not testing for COVID-19. They are straightly starting diclofenac and ketorolac. We have only paracetamol. It is necessary. Paracetamol is enough. Absolute necessary. Suppose the patient is already having an arthritis, then we can adjust the dose of the NSAIDs. Avoid using nebulized drug. Nebulization should be avoided in case of COVID-19, because aerosolization of the virus will transmit the disease further. Instead, we have to go for the meter dose inhaler. And oseltamivir should be initiated in all symptomatic patients with influenza-like illness till RT-PCR result is obtained. Especially in children, where oseltamivir is very helpful in influenza-like illness. And when there is in COVID-19, there is secondary bacterial or viral infection is uncommon. That is a beauty of the disease. So for the purpose of COVID-19, we need not initiate or continue antibiotics. Now we very over-the-counter antibiotic. They're starting with doxy, acitro, and both doxy and acitro are going in most of the patients. So there is no scientific base for that. It is just to given to prevent the secondary bacterial infection. But azithromycin can be helpful if it is given with ivermectin. So extended duration of the fever is typical in COVID-19 patients. So when the fever persists or cough persists, no need of any intervention. And antibiotic selection is in the case of secondary bacterial pneumonia is based on the institutional antimicrobial diagram. Now the GINA guidelines. GINA guidelines is global initiative for asthma. On the there is global initiative of obstructive lung disease guidelines have recommended continuation of the inhaled steroids along with COVID-19. Suppose a COVID-19 patients and COPD patients means COPD management should continue. There is no data to support or stop AC inhibitors or ARBs in patients with COVID-19. AC inhibitors or ARB may be continued in patients who are already on them. But if there is acute kidney injury or hypertension or any contraindication, we can think of stopping them. If secondary pneumonia is not improving on broad spectrum antibiotics, okay, when the secondary pneumonia is not improving with the broad spectrum antibiotics, consider the possibility of CAP. CAP is COVID-19 kappa. So COVID-19 pulmonary aspergillosis and our new entity, COVID-associated mucormycosis, which is the biggest header now. Now today the government has released the GO that it should be under notifiable disease. You know what is notifiable disease? You have to report all the cases that you are diagnosing to the IDSP, Integrated Disease Surveillance Program. So what is this COVID associated mucormycosis? So it is actually not a very new disease. It is very common in uncontrolled diabetes mellitus and those who are on long-term steroids and those who are on immunomodulator like now we have got the tocilizumab and we have got baricitinib, a new drug approved for COVID, baricitinib, which is Janus kinase inhibitor. Now, but what we are seeing practically is really different. We have to prove through our causation. Those who are long-standing oxygen are developing mucormycosis, and those who are in post-transplant or malignancy are associated with mucormycosis. Whether the humidifier bottle contamination is associated with mucormycosis, because we had a consultation with the various platforms where they say that only hospitalized patients are developing mucormycosis in some setting, not in all the settings. So that hypothesis we have to consider. And those who are on prolonged ICU stay, whether to rule out iatrogenic mucormycosis also we don't know. And chronic kidney disease and chronic liver disease, again a predisposed factor for mucormycosis. Those who are on voriconazole therapy, in post-transplant we will give voriconazole. That increased association of mucormycosis also. These are the various findings that is observed in the various states, especially in Maharashtra. What are the criteria for examination by ENT specialist? When will you suspect mucormycosis? When the blood sugar is more than 200. or when the HbA1c is more than 8, when the patient is having oxygen therapy for more than 7 days, or steroid therapy for more than 7 days in the hospital setting, especially, and use of tocilizumab and ICU setting for more than 7 days. These are the conditions where under the patient presenting with the nasal discharge or nasal block or sudden onset of blindness, we have to go for the mucormycosis. These are the various criteria to be for look forward ENT or ophthalmic specialist to rule out to mucormycosis. How to do, what are the test we have to do? We have to do the complete blood count and deep nasal swab, gram stain with the KOH mount, or calculus or white stain with the plate agar and deep fungal media sabro destros agar we have to use. And diagnostically nasal endoscopy should be done because of the mucormycosis, and the FS functional endoscopic sinus surgery we have to do. And CT PNS is very important because now the mucormycosis is occupying the sinus. Memory orbit is needed, and memory orbit, MRI PNS, and brain with the contrast because it is directly involving the brain. CT guided biopsy is needed in some settings, and whatever is the gold standard is the histopathology. Remember, mucormycosis is not the black fungi. That is a different group of fungus. Okay, mucorales. It comes under mucorales. It is not black fungus. Now various people are media are telling that black fungus. So it is not a black fungus. Black fungus is entirely different. So it is a mucorales. Okay. So management, the goals management is a control diabetes. Very important. Control diabetes. This is the most important. Reduce steroids dose. We can think of shifting to dexamethasone if the patient is on methylprednisolone. If that's the content of dexamethasone, discontinue other immunomodulating drugs. If already on baricitinib or tofacitinib, surgical debridement is needed, and the strict infection control measures are needed for to rule out the humidifier contamination. And we can consider the surgical debridement in case of involving the bones and the paranasal sinuses. We can think of surgical debridement. Medical management can be needed in the form of injection with liposomal amphotericin B. Now I am fearing that liposomal amphotericin B can become a next remdesivir. We don't know. Okay, so the best thing for the management of mucormycosis, prevent COVID-19. Prevent COVID-19 is the most important. We have to go for the COVID appropriate behavior and vaccination of the thing. So we have to prevent the COVID, because this mucormycosis again became a biggest headache now, because many people have lost their eyesight. So this again became a big issue. We can go for the amphotericin B management for 2 weeks, 5 to 10 milligram per kg. Amphotericin doses 5 to 10 milligram per kg for 2 weeks. Or we can go for dual therapy with oral posaconazole, 300 milligram twice daily, 300 milligram twice daily, followed by three on day one. On day one, followed by 300 milligram OD for 2 weeks. Okay, so this is another thing. And amphotericin B, when you started a liposomal amphotericin B, we have to do RFT. RFT is mandatory because it will cause hypokalemia. Okay, so prevent COVID-19 is the best management for the preventing mucormycosis. Okay, so now the rule of 3. What is the rule of 3 in management of the COVID-19? There will be 3 minor symptoms in COVID-19 which we should not ignore, or we should always suspect COVID-19. Anosmia. Anosmia is almost considered as positive RT-PCR now. Altered taste, okay, cold, stuffy nose, myalgia and throat pain. Now, suppose post recovery also, this anosmia will take 6 months to recover. Okay, so for that, many patients are asking me how to my smell sensation not recovered, my taste sensation not recovered. For that, we have to go for the fragrance or aroma therapy. They have to take lime or lemon, and we have to constantly do because olfactory receptors are destroyed in COVID. So they have to go for the training of this. In US and all, they are going for the fragrance scent to regain the smell. Okay, so that is another post-COVID headache. 3 must-have things in home isolation: pulse oximeter, thermometer, and the details of the emergency doctor. This is another area why Abdul Hassan sir told that in the initial way the home isolation is not working, because many of them was not able to buy these 3 things, and they don't know, they don't have the education to monitor how to use pulse oximeter, how to use thermometer, how to so where to contact. These kind of things are not available. But I feel when the patient is good enough or educated enough to monitor these 3 things, they can go for home isolation. And 3 things to be monitored daily. What are things to monitor daily? Obviously, pulse oximeter with the 6 minutes walk. When the saturation less than 94, they have to report immediately. Temperature, especially after 4th day, if the temperature is sudden incident, means we have to go for CRP and starting steroid. If the CRP is increased, tachycardia, and they have to monitor daily heart rate. They have to check. And the pulse oximeter also have the heart rate, so we can go with that. So pulse oximeter teaching is also very important. Many people don't know which finger to use, how to use, like that. 3 lab parameters very important in the form of complete blood pressure, complete the blood picture, and the CRP, ferritin and LDH, and D-dimer. 3 reasons for late presentation. Why people are coming with late presentation is they even though we are seeing that they were now we are seeing the post vaccination also people are developing COVID. I have the explanation for that. See, the vaccines Covishield or Covaxin, where it's Pfizer or Moderna, they are tested to prevent hospitalization. They are not tested to prevent disease, okay, or infection, okay. So but to be frankly say that those staffs in our hospital who are vaccinated never developed the complications and they never landed in ICU, okay. But what happens is, suppose a patient after vaccination develops COVID-19 not because of vaccination, some exposure pattern previously, so they'll attribute this fever to post vaccination. If the fever persisting for more than 48 hours, we have to test for COVID. And using Dolo and paracetamol over more than 7, and they will go for masking fever. They are masking fever. They should report that even after continuing use of paracetamol, fever thing they should report. So it's a kind of, patient has to himself or herself has to become his own doctor to in this to prevent the late presentation. Wrong timeline. Now the people are confusing that testing day is considered as day 1. No. Day of onset of the first symptoms is considered as a day 1. So that is the reason for the late presentation, that reason for the more monitoring. Moreover, I am very sure that if there is the doctor patient the relationship or the thing continues, we can go for home isolation. 3 things to avoid while on treatment. WhatsApp University better avoid. Okay, they're causing a lot of anxiety because mental health is so vital in management of COVID-19. I already told that 90 to 95% are got cured. They're not even going for complication. Only 5% is going for complication, was because India is reporting 276,000 per cases per day. All of them are not going for hospitalization. Okay, avoid, especially watching news. We should educate the patient, or we can put it in our prescription sheet itself that do's and don'ts. Avoid was especially Google updates or YouTube COVID-19 updates. Okay, there will be a lot of controversial people are going there, so avoid that to make safe. Okay, so now we coming to the read history, answers are there. Coming to the answer of COVID-19, when it will end. The COVID-19 exactly following the 1918 pandemic, when there is an influenza that is happening, where there were 4 waves. 4 waves. In 1917, the disease started. First wave happened in 1918. Here, 2019, the disease started. 2020, we have the first wave. And this second wave happened in 1919. Again, we have 2021, the second wave. Third wave happened in also 1919, later part of 1919. We have to see. Okay. But the thing is, during 1918 pandemic, there was no vaccine. Vaccines were available only in the later part of 1920. So what is the classical similarity between these two pandemic of COVID-19 and 1919 pandemic is SARS, it is caused by SARS-CoV-2 and this is caused by H1N1 and mortality rate is almost same. It is almost same. Okay. Number of deaths is 2.2 million and counting, and we have 55 million deaths in 1919 pandemic. Highest risk population is 65 plus comorbidities. There is 25 to 40 because those time life expectancy is also less now. So that is also almost severe. And the cause of death in COVID-19 is not due to virus, it is due to the overactive immune system, leading to end organ failure. But the cause of death in 1918 pandemic is secondary bacterial infection, and the origin is in Wuhan, which is in Kansas, almost similar. So this is a similar kind of thing. The second wave will peak by May second week, which we predicted, and this is come true, and it started reducing by May last week. Now itself, Delhi, Uttar Pradesh, Maharashtra, there is a start reducing the cases because of their lockdown and the curfew measures. And second day will be at end by late June, as per the prediction of the modeling pandemics. So we can have the second wave endemic by prediction by the late June. Okay, and so third wave, there is a lot of misconception is going on that it will come in expected by October or November. Actually, we can expect in December. Actually, 6 months after that. This is a news media report. And children or pregnant women will be at risk, but you should know that they are not only at risk. They are also the people who escaped the second wave will be at risk. And third wave will have more pneumonitis and the JA symptoms. And there will be a lot of variants of concern is also there because of the third wave may come, because after the once the lockdown is released, again people will not follow this COVID appropriate behavior. So variants of concern, we have now double mutation, we have triple mutation, so that will have the third, that is maybe the reason for third wave. But vaccines are also there, so vaccines may help us to prevent the third wave, but it's completely depends on the hands of the government to frame a policy network. How can we go for the vaccination of the third wave? And what are the variants of concern? What is variants of concern? Because there are 6 variants. We have England, UK variant, we have South Africa variant, we have Brazil variant, we have the double mutation, we have triple mutation, and we have the latest controversy Singapore variant is also there. Actually, Singapore variant is not real variant, is actually Indian variant that is transported in the that got occupied in the Singapore, as clarified by the Ministry of External Affairs Singapore. Because when the circulating virus is more, so that induce more mutation. So for that only this home COVID appropriate behavior is more important, which will prevent the formation of mutation. And we can say that current vaccines have role. Both Covishield and Covaxin are completely effective against this new variant. There is no need of getting fear. If at all the new variant comes, we need to do genome sequencing. When I do the genome sequencing and incorporate that variant in the new vaccine, we can be protected against these variants of concern. So that should be done, planned by the government. Already Maharashtra has started this genome sequencing. So we have to wait for each state has to come up with one policy of the genome in sequencing and to find out that variant and incorporate that variant in the next schedule of the vaccines. So seriousness, yes, third wave, if it comes, it will be very severe, because if it comes, I feel, because government will not allow that. The first wave, the virus would kill the lungs in 10 days. Second wave, the virus will be 5 to 7 days, as we are seeing now. Third wave, it will be more severe. It can be even 2 to 3 days, the lung damage will occur. So individual level, how can we promote the prevent third wave is, you should avoid social media and news channel to preserve our mental health. Steam inhalation, again, people are doing, it is not proven that steam inhalation will cure coronavirus, but steam inhalation definitely will help in symptomatic management, because coronavirus will die only at the temperature of 56 degree. If you steam inhale at the rate of 56 degree Celsius, you will have skin scald. We will have burns of the skin. Okay, and suppose the lung structure is like that, the steam has to reach the peripheral alveoli where the coronavirus is there, but 99% the steam will not reach there. So scientifically, steam inhalation and will not help for coronavirus, but it is very helpful in symptomatic management and psychological advantage also there. It is not harm also, but they should use judiciously, only 5 minutes a day or twice a day. Now people are doing 10 times a day, 20 times a 12 times a day, which is absolutely wrong. Okay, then whenever something is coming, they're taking it excess. That is our policy. Meditation and nutrition, we have to continue more fruits, vitamin C and zinc. And the most important thing which I want to write and mention is vaccination. Vaccination should be done to prevent third wave. That is the only solution for us. Because that is the only weapon that is working against the COVID-19. Even remdesivir has some lot of forest, but it's not working. So how to prepare and prevent? We should have more training on pediatric and OG COVID-19 guidelines. If IMA decides, I will have more presentation on this also. How to prevent, how to manage OG guidelines, how to go for pediatric guidelines, and we should go for setting up of more pediatric and OG COVID-19 wards, because children cannot be managed at home. So we have to go for the separate clinic thing, procurement of steroids and anticoagulants in advance. In federal that way and advice. And most important is, this is the most important, government should start thinking adolescent vaccination. And positive news has come in the form of Covaxin, which is approved for the 12 more than 12 years vaccine trial. Okay, they have done for this. So adolescent, because virus directly not jump to less than under 5. It will go slowly. It will first target adolescent, then the children. So government should think of some policy, or we have to put something to the government to go for adolescent vaccination. That is more important. If adolescent vaccine is done, we can confidently open the schools like Germany has did, like Scotland has did, and Austria has did. They open the schools after adolescent vaccination. And adolescent vaccination has already started in many countries. The Pfizer has already started the adolescent vaccination, and this vaccination adolescent will prevent the third wave in COVID-19. UK, some study has been reported. So I think that with the government will approach proactively and involving public health experts, we have to prevent third wave, because we don't have them. If we don't have the enough healthcare structure to face the third wave. So we should think of the adolescent vaccinations high priority, but the reality is very, we don't have the vaccination to vaccinate even 18 plus also. But I think the government will start more procuring of the vaccine, and everything has an end. Similarly, COVID-19 also has an end, and this too will pass. Okay. So thank you so much, IMA, for the opportunity. I think I have maintained my time of 40 minutes. Okay. So thank you, Venkatesh, and thank you the whole IMA bearers for this opportunity. Thank you.
Thank you, sir. Thanks for the enlightening session. I'm sure that all the participants have benefited in a huge way from this. The number of participants at the beginning of the session and at the end of the session is the same. So this is, and I wish this is going to reflect directly in the management of patients. If audience have any questions, they can start typing in the chat box. We'll have the discussion now. In the meantime, I request our IMA JDN General Secretary, Dr. Karan Juneja, to talk few words about the IMA COVID helpline. Over to Dr. Karan Juneja.
Thank you so much, Venkatesh. It is a great session by Karan sir. And I think it is very inspiring to all our volunteers who have been working tirelessly, attending to 5,000 plus calls, and Abul sir who keeps reporting us and inspiring us to keep the momentum going on. And I think this is a true tribute to our past national president, Dr. K.K. Agarwal sir, that we continue this good work. It was his wish that all our his sons and daughters carry on serving the people at this time of crisis. And I'm very happy to tell you that in the morning, as per the data which Abul sir had uploaded on Delhi Police Helpline, there has been our volunteers have attended to 3,084 plus calls till now, and their calls have been regarding various mild symptoms. People have been asking regarding vaccination, and there's a very good momentum going on. People are getting aware, as well as Tamil Nadu helpline, which is being run very well by you, Venkatesh, and Manikandan sir. And I'm very happy to tell you that the response which is coming from Tamil Nadu helpline is great. And I think similarly, we had been running since April 15th, we have been running national helpline also. And we have been helping each and every call which is being attended by Taheen, and the queries used to come and we used to keep solving them and doing the procurements. And as sir has suggested, we have now stopped for the drugs like remdesivir and all, so that we are not just basically focused on drugs procurement and all that. We are basically in patient counseling, as well as now we are focused much more to advise the patients to use the drugs very judiciously, steroids and remdesivir. And I think this session has been very useful to all of us. And thank you, Venkatesh, for organizing it. As always, you have been great. And thank you, Shiv sir. Thank you, Abul sir, for joining along, and Kanan sir for very elaborating it in a very concise and a very very informative manner. And thank you so much. I think we should now see the queries and questions. Thank you.
Thank you, Dr. Karan. Now it's time for questions. The first question is from me. So as we know, there are different guidelines which are coming up in a very short span. For example, Tamil Nadu was recommending ivermectin. Suddenly, Tamil Nadu dropped the usage of ivermectin. In the meantime, AIIMS said that there are some evidences which supports the use of ivermectin, but not sure about it. So in such case, as a junior doctor who is directly working in COVID wards and seeing COVID patients, whom should I follow, sir? Should I follow AIIMS Delhi or my own parents institute or my state? Whom should I follow? Kannan, sir.
Yes, sir. It's a very important doubt, Venkatesh. Thank you for asking this doubt. As many states keep on changing their guidelines, each state are presenting the guidelines based on their state epidemiological characteristic of the epidemiological characteristic of the disease. In states where there is more number of mild case, ivermectin is definitely a useful drug. But the case where when there is state where there is more than moderate to severe disease, ivermectin still can be used, but states are not using. Maybe the reason for the shortage. So it depends on you follow your own departmental protocol or state protocol, because the state health will know the epidemiology of the disease.
Okay, sir. Thank you, sir. The next question from Dr. Shweta Rajeshwari. Madam has asked that there are incidences reported that despite 2 doses of vaccinations, there are deaths being reported in the recent few days. What is your thoughts on this, sir?
Yes, I think that the various media, they are already the vaccination incidence is going on, and the media people are already started speaking on that. Even they talk about our own IMA leader, and they're talking about that. But the actual reason is they may be on immunosuppressant. If the patient is be on immunosuppressant, the vaccine may or may not work. Still, vaccine will prevent the morbidity on the that mortality of the patient. So that depends on the patient. The patient is on long-term, very long-term immunosuppression, the vaccine will have the impaired immune response. But that happens very rare. No? It happens very rare. One in 1 lakh cases only it is happened. But majority of the vaccination, it is, as I told, no, in my setup, we have vaccinated almost all the staff. Many developed COVID positive, but the hospitalization is extremely rare. Okay, so that may be the reason. But vaccines are still work. We should bring a hope on vaccination, and we should propagate about vaccination. That is the only weapon.
Okay, sir. Thank you, sir. Another question: is booster dose for COVID vaccination required? What is the role of booster dose in COVID vaccination?
Yes, booster vaccination is told by some other countries. That again, it depends on the epidemiology of that country, where how they are able to control their public, how their public behaviorism. That depends on the booster dose needed. Since our current vaccine are mRNA and this vaccine, booster baby may needed, but it depends on the case scenario during that time.
Okay, sir. Okay. And Dr. Harshal is asking, which is the best vaccine?
Again, a very good question. Covishield or Covaxin? All of the vaccines are good. It is a tough question to answer, because if you are asking a married man, who is important, your wife or your mother, or asking your married woman, who is your best, your father or husband? So it's a kind of that question. All vaccines are good, but none of them will prevent all of them prevent the hospitalization and the death. So any vaccine is good only.
Thank you, sir. Another question from Dr. Karthikeyan. What is the difference between black fungus and mucormycosis, and why it is rising?
The mycological classification is different. This comes under mucorales. That is black fungus is the different entity. Black fungus, why they mentioned is because it is causing that necrotic thing. No, so they labeled as black fungus. Microbiologically, it is different. So it is a mycological classification. So not related to the clinical thing.
Thank you, sir. So another question from Dr. Gayatri. What is the role of urinastatin and baricitinib in the treatment of COVID-19?
Yes. Again, they are immunomodulators. Still, we need a lot more data in efficacy of preventing hospitalization. That is not there. But they are used only for the severe cases. So effectiveness, we have to wait for some more studies. Like tocilizumab, they have studies, but this olinastatin and baricitinib or Janus kinase inhibitor, the effectiveness we have to see whether they, but in some pockets they have reduced the hospitalization, but it is not recommended in our protocol. We have to wait and see because of the lack of data.
Okay, sir. The last question from Dr. Kuldeep. Is there any role of oral anticoagulants post-discharge in a patient who has recovered from moderate to severe COVID-19 infection?
Yes, again, very good question. This is the most thing we are needed. So the thing is, the anticoagulants has to be continued for 3 weeks even after the discharge to prevent the vascular events. So that the role is there in preventing the coagulation and clot formation in the post-COVID. So it has its role. We have to continue for 3 weeks.
Okay, sir. So a few more questions popped
Yes.
up. Dr. Dinesh has asked, I have recovered from COVID. Almost 7 days of quarantine is over. Is it possible to get reinfection if I start working again?
Yes, this is another question. Still, you have to follow the COVID appropriate behavior. But if you get infected, the antibodies will be there for a few minutes time, so that may help. So there's a chance of getting infected till the pandemic is there. So we have to follow the COVID appropriate behavior.
Okay. A question from Dr. Deepak. My grandfather has got Stevens-Johnson syndrome 10 years ago. Is it safe to take vaccine now?
Yes, it is absolutely safe to take vaccine if he is not on steroid. If he is on steroid or any blood thinners, we have to consult with your doctor and reduce the dose, and preferably please take vaccine. It is not a contraindication for vaccine.
Okay. Thank you, sir. Dr. Anuvashni has asked, is the efficacy of Sputnik higher than the other vaccines?
Yes, good question. Sputnik efficacy is 91.6% against hospitalization, whereas Covaxin and Covishield, the thing is Covaxin is around 80%. Covishield is 71% against hospitalization. Now they increase the dose of Covishield from first dose to second dose to 3 weeks, so that may improve the efficacy. Efficacy of Sputnik is higher in the data. It is higher only.
Okay.
But again, that does not prevent the disease. It will prevent hospitalization only. Okay, Amrish.
Okay. So I'm taking the last question, sir. We'll stop with this. Does corona spread by fomites?
No, still not reported.
Okay, sir. Okay, sir. Thank you so much, sir, for being so patient and kind towards us. So now I request our IMA Junior Doctors Network convener and my mentor, Dr. Shiv Joshi, sir, to deliver the vote of thanks.
Thank you, Venkatesh. And thank you, Dr. Kannan, sir, for presenting this relevant session today. It was heartening to see the time and efforts you put in this presentation to make the things simpler to understand for us. We thank Dr. Abul Hassan, sir, our Honorable Chairman of IMA JDN, for being here despite his commitment amidst the pandemic. Extend my gratitude to Dr. Venkatesh Karthikeyan, who took up the initiative to arrange this wonderful session on behalf of the IMA JDN. And we appreciate his team and clearness to make this session flawless and glitch-free. I thank all the curious and active delegates for participating in this session. IMA JDN is one of the largest representative organizations of junior doctors under the patronage of IMA, and we have committed to stand for the rights of this fraternity. We invite you to join us and participate in our future activities. Thank you.
Thank you, sir. Thank you, Clarinet. Thank you, Abul Hassan, sir, Shiv Joshi, sir, Karanjane, sir, and most importantly, Kannan, sir, for the wonderful time you have given to us. We will all see you soon in one more interesting session in the upcoming weeks. Thanks for joining. Thank you, everyone.
Thank you so much.
Thank you, sir.